Thank you.
Okay, good. So, so we're going to talk about glaucoma assessment and diagnosis, and I'm coming at it from a high street optometrist perspective. Okay, so if you are, but it will be relevant to people working in community or in hospitals, for example. So we'll be going through quite a few things now because we've got reduced time because of the peer review at the end. I'm going to be skipping some of the slides. You should all have had the handout from Michelle. So some of them you can just read. Okay, so you'll notice I'm skipping over some things. Right, so we know glaucoma is an optic neuropathy. We know it's progressive, and we know that you have characteristic changes. You get loss of retinal ganglion cells, and then the axons. And then that causes changes in the optic nerve head, and then you get vision loss if it's untreated. So the main risk factor for glaucoma is either having a high pressure, glaucoma developing in the first place or getting worse is a pressure higher than your optic nerve can cope with, which is usually above our statistical upper limit of normal, which is 21. Bear in mind that up to 50% of people will develop glaucoma at pressures 21 or less, so do bear that in mind. Glaucoma is a really important cause of loss of vision, accounts for 10% of blindness registrations. It becomes commoner the older, more prevalent the older you get. And just to make you remember that actually, while we think of primary open angle glaucoma as atypical glaucoma in the UK, up to 15% of glaucomas are angle closure. So it's not as rare as we used to think it was. So we know it's generally painless glaucoma, so even the angle closure is generally painless. It is progressive, and the visual loss is irreversible. So if you don't treat it, you end up being blind. You get these characteristic structural and functional changes. So we think about glaucoma changes in two ways. So structural is anything to do with the optic nerve, what you see, what you measure of the optic nerve, and then the functional loss is what happens to your vision and the visual field. So with your optic nerve, what you're having, the optic nerve rim is what we're going to be looking at. That's what carries your axons of your retinal ganglion cells to your brain. Okay, so you're going to be assessing, when you're looking at the optic nerve, what you're trying to assess is how many retinal nerve fibers do they have? Do they have a normal amount or not? So normal cup here you've got someone with moderate cupping, and you can see the arrow pointing to a area of focal loss, and that focal loss has a nerve fiber layer defect there. So that's moderate glaucoma. Here you've got advanced glaucoma where the person's lost the majority of their nerve fibers. So you want to have in your idea how much do you think of the normal amount of nerve fibers do you think they've lost? About here, you've lost about 90–95% of your nerve fibers. So when you come to the functional changes, we have to assess vision, but visual field is the main thing. So what we tend to have is, again, these characteristic visual field changes. You tend to get arcuate scotomas, either superiorly or inferiorly, a nasal step, and over time they will coalesce and move centrally and peripherally, and you'll end up with the advanced stage having just a tiny island in the middle usually. Let's skip over that. So let's look at how we compare structure versus function. Now the difference between how structure and function monitor your progression of glaucoma is to do with basically the logarithmic scale that we have with our automated perimetry. So if you're looking at the disc changes themselves, there's generally an almost linear change over time as the glaucoma progresses. If you're looking at RNFL thickness, as we do with OCT, you find that there's a general decline early on, and then it tapers off towards the end of the disease. And with visual fields, the opposite happens. You can get not much change early on in the glaucoma. As the glaucoma advances, you get much more change, and then it slightly tapers off towards the end. So what that tells us is that you can use the optic disc to monitor for progression of glaucoma throughout the person's lifetime. OCT is generally more helpful early on. Visual fields, not so much change early on, but very much more important when you have later stage disease. So what types of glaucoma do we have? You're going to have to think of glaucoma as primary and secondary, open or closed. And there are a whole heap of things that can go in there. And I have added ocular hypertension and PACS, which are precursors, sort of risk factors for developing glaucoma. And then always remember that you can get developmental glaucoma. So that's glaucoma in babies and children. It can sometimes be picked up late, so or develop as in their teens, and then tend to call it juvenile glaucoma. So every type of glaucoma, barring these ones, should be able to fit into one of those categories. So you see the primary or secondary, open or closed, and there is a spectrum between those. So what do we mean by open? What we mean there is that there's no mechanical obstruction to aqueous get into the trabecular meshwork, okay? So the problem is resistance at this level. With angle closure, we've got a mechanical obstruction to aqueous actually get into the trabecular meshwork, canal of Schlemm and thereon. So that might be iris or it may be something else. I'll skip over that, and I'm going to skip over those because I'm going to get you guys to read those. Okay, so how do we diagnose glaucomas then? So if you're an optom in the high street, got two sets of questions I need to be asking yourself. You've got the patient in front of you. Do they have any glaucoma risk factors? So is there any reason why I should be looking for glaucoma or expecting glaucoma in this person anyway? If you think there is, or as part of your examination, you decide, okay, there's something odd here. Do they have evidence of ocular hypertension, glaucoma, or something that makes them suspicious of developing glaucoma or having glaucoma possibly? Everything else gets looked for in the hospital. So that's your role as high street optoms. Now, unfortunately, glaucoma doesn't have much in the way of clinical features, symptoms until late in the stage of the disease. So it's only usually when you've lost, generally about half your nerve fibers that you start to be visually symptomatic. And that's a problem because you've already lost retinal function that you can't improve or replace. So most of the time we have good central vision until late in the disease. Okay, so Snellen acuity, for example, is not going to be a good indicator of how advanced their glaucoma is. Now, why do they not notice? So I want you to look at these pictures. So this is someone with bilateral glaucoma, left field of view, right field of view with both eyes. Okay, so we commonly see the pictures describing, depicting glaucomatous field loss as a black area in their field, and that's not right. So what you have is a kind of smudging and loss of detail. So you can see this is what actually, we're trying to represent how that appears to that person. It's sort of smudging of the vision. So it's not quite so obvious. So this is an inferior arcuate in the left eye, a superior arcuate in the right eye. Now, with both eyes open and your overlap, they don't notice anything. So they've got the full picture. So quite often they only notice that field loss when they inadvertently cover one eye or the other, or something happens to one eye, and then they're only looking with one eye, and that's when they realize that actually, oh, there's something wrong with my vision. But they may not even always be aware that this area is essentially a blind area in your vision, and that's because your brain doesn't like vacuums, so it makes up things. So what it will do is take the image here, the image there, and create something in between. So we've talked already about how we diagnose glaucoma. So you've always got to think about three things: risk factors, typically raised intraocular pressure. What's their function? Is there any functional evidence of glaucoma? And is there any structural evidence of glaucoma? And you put all those, you get the strongest evidence for glaucoma when you've got all three things. Okay, so you're going to ask the questions, you're going to examine the patient looking for risk factors, you're going to have to assess visual function, and you're going to have to examine the eye as well. I'm going to skip through those because you can read those. Right, so what are you going to be doing when you're assessing a patient? You're going to be assessing their visual acuity because you've got to say structural and functional changes. You're going to assess visual acuity. You may not be refracting them if it's not a standard GOS, but knowing about the refractive status of the patient is really helpful. So if you have a hypermetrope, they're more likely to have angle closure than open angles. If they're myopic, they're more likely to have open angle than angle closure, and they're again more likely to have pigment dispersion. So refraction is really helpful, and when you're referring someone to the hospital, we really like to know what their refractive status is. You're going to be performing some sort of automated perimetry. You're going to be measuring the intraocular pressure. Generally, ideally, if you're referring anyone to a hospital for glaucoma, we want Goldman tonometry, and all optometrists are supposed to be able to do this. So we really do expect to see that if you're referring someone, and that's because all our evidence is in Goldman tonometry. We don't have evidence for aura or eye care, and definitely no evidence for non-contact. You're going to be trying to decide whether they're likely to have narrow angle glaucoma or an open angle glaucoma. So we want to know about Van Herrick grading. We're not expecting you to perform gonioscopy. you're going to have to assess the optic disc. Okay, again, I just put these two pictures: Caucasian retina, African retina, subtle differences. So, you know, the pigmentary changes. So don't let that alarm you. And I put here particularly, we do not need an OCT of the optic disc for a referral. Okay, so the only time you're going to be doing an OCT if there's something very abnormal that you want to show us. And generally, one wants to get out of the habit of requesting investigations that you can't interpret yourself. Okay, because you're going to have a patient in front of you expecting you to be able to say something. And you need to be able to say something sensible. You don't want them to come to us first just to say, you know, that was rubbish. Okay, so we definitely don't need OCT. If you've done all these things, that's all we need. So when they come to us in the hospital, we'll be looking at color vision to try and exclude other causes of optic neuropathy. We'll be checking their pupil responses. We'll be performing gonioscopy. We'll examine the disc, but we usually do some sort of optic disc imaging as well. And we'll be measuring the structural function, the structure, sorry, of the eye, which will be retinal nerve fiber layer. And we also now look at the ganglion cell complex, which gives us information about earlier glaucomas. Because we already said that they start in the retinal ganglion cell, and then it's the axons that you measure at the RNF, the peripapillary circle here. Okay, so if you're looking for the ganglion cell changes, you might pick it up earlier. So I'll just go through these. So again, you're thinking, you have to have the back of your head, you know, what evidence am I looking for? So you're expecting the pressure to be raised usually. You generally won't have access to pachymetry, but they might have told you that their cornea is thin, and you can assume that cornea is probably going to be thin if they've had refractive laser and they were myopic. What you're going to be looking for and expecting if they've got glaucoma is increased cup to disc ratio, which is just not proportional to the optic disc size. You're going to be looking for rim loss, be that focal or general, looking for nerve fiber layer defects and visual field defects. Specific things you'll be looking for are to help you determine what type of glaucoma might it be. Is it primary or secondary, or open or closed? So look at the anterior chamber, the iris and pupil, look for pseudo-exfoliation, look at the lens, are they phakic, pseudo-phakic, aphakic? That would be a common cause for secondary glaucoma. Where's the IOL? Is it in the sulcus? Is it in the anterior chamber? Again, commonly associated with secondary glaucomas. You're going to be performing Van Herrick to determine whether you think it's open or closed. The commonest secondary glaucomas would be pigment dispersion and pseudoexfoliation. Pseudoexfoliation is really common in people more from Celtic origin, Scandinavia, Cyprus, Turkey, and so on. So just knowing someone's ethnicity can put you a point in the right direction as what to look for. If you think it's pigment dispersion, look for endothelial pigments, iris transillumination defects. You really see those most in the lighter colored eyes, so the blue and the hazel and the gray. You don't be surprised if you don't see them in someone with a dark brown iris. The hallmark of pigment dispersion syndrome, however, is seen as conioscopy when you see increased trabecular pigmentation. Pseudoexfoliation, look at the pupil edge. When you dilate them, look on the lens surface. If they're very well dilated, you can sometimes see them on the ciliary processes, little white flakes. And when we do the angle, we may see dusting or just increase in pigmentation. Eye size is helpful. So hypermetropes usually have a smaller than average eye. Myopes usually a larger than average eye. So knowing that can give you some idea of what kind of glaucoma they're likely to have. And in the hospital, we actually measure that, and that can give you very useful information. So how do we evaluate the optic nerve head then? So 5 things to think about. You're going to evaluate the size of it. You're going to evaluate the rim, okay? And that's what you're trying to do when you measure the cup disc ratio. You're going to look for RNFL defects, and I'm afraid this is quite subtle here, okay? And superiorly, we've got one there. So they tend to be wedge-shaped things, narrowest at the disc. You're going to be examining the parapapillary area, looking at your alpha and beta zones, and looking for disc hemorrhages, okay? So if you see any of those things, you're going to something. And when you're examining the disc, you're going to be talking about all the various characteristics, bayoneting, bearing, things like that. So we've talked already about why you assess for cup disc ratio, because you're trying to estimate the neuroretinal rim area. So you're going to measure the cup vertically, and you're going to measure the whole disc size vertically, and then you're going to compare. But actually, cup disc ratio without disc size is actually not terribly helpful unless you can show that there's been progression. It's gone from 0.3 to 0.7 in the same eye, then that would be useful information. And this is why. So I've got a small, all three of these eyes have the same rim area. Okay, so the same amount of retinal nerve fibers, axons there. So this eye though, because this disc, because it's small, the cup will look 0.3. Here the cup is 0.5 because they've got a moderately sized disc, and here you've got a very large disc and the cup disc ratio will be 0.8. Now most people refer that and think this is fine, but if you've got a really small disc, that might be glaucomatous, so they may have lost nerve fibers already. So you're going to measure. Okay, so that's something that's worth trying. Now you need a graticule on your slit lamp. You need a bright beam of light, a narrow beam, and you're going to center it on the middle of the disc because that's our standardized position for measuring. So you measure it there. You need to have the optic nerve head sharply in focus, and then you measure the line. Okay, if you've got your optic nerve head out of focus, that measurement will be inaccurate. EGS guidelines, that's the European Glaucoma Society, tell us that for Europeans, the average disc size is between 1.5 to 2 millimeters. So if you're larger than 2, then you're larger than average. Shorter than 1.5, then you're small. Okay. Generally in the hospital, we measure with either a Super 66 or a digital 1 times, and that's because we don't want to have to worry about correction factors that you get from the different lenses. All right. So if I use a Super 66 or a digital 1 times lens, whatever I measure on here, if I measure 1.7, is the actual measurement in 1.7 millimeters. Okay. For all these other lenses, you need to correct that. Now, I would ideally say you're looking at a disc, you're looking for detail. Please don't bother with these lenses. Okay, you really want to get a good view of the disc. So you should be going for these types of lenses ideally, not 90, because you'll miss detail. And just a reminder again that actually your assessment of the pupil of the optic nerve head is always more accurate if the pupil is dilated. So these are all the kind of typical characteristics, and I'll leave you to read those, but let's go through some of them. So what I'm going to ask, what I want you to do yourselves at home is to try and match these features. Okay, so nasalization of the vessels is a glaucomatous feature, as is bearing. So we're saying that the vessels have moved away from where they should be. Disc hemorrhage is a feature, as is a notch, so a focal area of thinning of the rim, and bayoneting where the blood vessels go underneath the rim. So I'm going to give you about 30 seconds, have a look, and then I'll give you the answers. Okay, so let me put the answers in. And the arrows show you where I want you to be looking. So here you can see bearing, everything, the vessels have moved away from the rim, that's not usual. Here you've got a notch, so focal loss with a nerve fiber layer defect. Here you have nasalization of the vessels. They've all kind of moved because the vessels like supports, so they move to where the support is. Here you've got bayoneting. The blood vessels have gone underneath, and it's almost like they've gone underneath the surface, so you can't really see them. So that's the bayoneting, and here you've got a disc hemorrhage. Okay, so look for all those features because that increases the likelihood that that person has glaucoma. Let's look at retinal nerve fiber layer defects then. So don't know if you can see this one here. I might just turn the light off in case it makes it any better from here. So retinal nerve fiber layer defect is where you've lost nerve fibers and there's a change in the architecture and the color usually of the retinal surface. So here, those arrows try and show you this slightly darker area here. That's where the nerve fiber layer defect is. And because it's a dip into the retina, you might notice that the blood vessels seem to dip down. So there's a kind of contour here of the vessels going into that slight depression. Okay, so look for changes in the contour of the vessels. That is a bit unusual. Now, so this is a healthy nerve, particularly in a young person. You get these grayish sort of white striations from the RNFL, so that's normal. Okay. When you have global diffuse RNFL loss, the blood vessels become more pronounced. Okay, so they're more visible because you haven't got that RNFL that's sort of causing the edges to look a bit more blurred. And if you want to look for RNFL, a red free light or a green light is much more helpful. So I'm going to show you this one because it was quite interesting. So this is a patient with quite pronounced RNFL defect here and there, okay? And this is an OCT, and this line tells you where the cut was. So that's through this upper one. And can you see how we've actually lost, you've got a sort of defect there, yeah? So you've actually lost structure of your RNFL in that area where you've got the RNFL defect. Okay, so that's the anatomic feature of what you see when you're looking at the retinal surface. Let's go on to visual field then. So we have our characteristic field changes that we associate with glaucoma, and that helps you distinguish between glaucomatous field defects and other field loss due to other optic neuropathies. Okay, so you're looking for them in characteristic places. All right, so these are the characteristic areas where you have it: your nasal step, your paracentral area, usually because there's a focal loss of at the rim right up to the edge. Here you got your gerum area, and this is your typical arcuate area. This is to try and help you relate disc to field. Okay, so the better correlation there is between the optic disc appearance and the visual field appearance, the more likely that is to be true and to be glaucomatous. So what you're saying here, this inferotemporal, this is for the right disc and the field associated with that right disc. This inferotemporal area is the commonest area to have field loss. That's your macular vulnerability zone. Okay, so that's there. So this area here, A, is going to give you a superior arcuate. Now this inferior thinning here gives you a superior arcuate that extends all the way to the nasal step. The superior equivalent, your superior-temporal area, gives you an arcuate, but it doesn't go right up to the edge. So that's the difference. So they're slightly different. To get a nasal step from the superior rim loss, you have to be in this sort of area. Okay, so you want to look at your disc, look at your field, and do they match? All right, and the better they match, the more accurate. So let's look at that practically now. So I'm going to concentrate on the right eye. So this person has glaucoma. They've got some arcuate-ish type defects here. Okay, although a little bit unreliable. So there they are. Okay, this is the disc. So you can see they've got a bit of tilt. They've got some inferotemporal thinning. So again, thinning this macular vulnerability zone. We already know that's supposed to give us a superior arcuate, okay, which they have. Okay, so that's supposed to be there, and we have that. And then this temporal area is more likely to give you something here. Okay, we don't actually have anything much coming up here on there, so that's not showing up. All right, but those are the areas that you need to be looking for. You may occasionally have people present to you on the high street with acute glaucomas. Now, if an acute glaucoma is usually a symptomatic glaucoma, most of the time they're due to angle closure, but it can also happen in open angle glaucomas. All that has to happen is that pressure goes up suddenly enough to cause inflammation in the eye. Okay, but in these features are for acute angle closure happening in someone with that's predisposed to primary angle closure. So they'll typically have quite a severe headache, nausea and vomiting. They may see halos around lights. The eye will be painful. They'll have light sensitivity. They'll have reduced vision. The eye will look red, typically a limbal injection. The cornea will be hazy because that high pressure and inflammation is going to cause corneal edema. The eye will feel firm to touch, even if you can't measure. And the pupil will usually be mid-dilated and unreactive, or at least quite sluggishly reactive. It's much more likely that all these sort of features are due to acute angle closure if you have someone who is predisposed to angle closure, if they've got small and hypermetropic eyes and they've recently been dilated. So we quite often see this precipitated in patients who've gone for diabetic screening, for example, or when they've had their pupils dilated either in the hospital or in fact with optometrists at the high street to look for some retinal thing, and the person has failed to recognize the fact that they've got a shallow anterior chamber or a narrow Van Herrick. In the hospital, this can sometimes be diagnosed as a neurological emergency because they will think, and they come to main A&E, they might think that headache, nausea and vomiting means they've had some massive cerebral event, raising intracranial pressure or a bleed or something. So if it's really helpful if you can pick up, if you have a phone call for something, a patient calling you, if the eye is red itself, do think about that, all those symptoms being eye related rather than cerebral brain related. Now, what I want you to do is think, okay? So we've talked about primary and open angle glaucomas, different things, whether they have glaucoma at all, whether they have OHT. So you've got a patient presenting to you, 44-year-old male, who has a pressure of 56 in the right eye and 18 in the left. Cup-dish ratio is 0.6 on the right, 0.35 on the left. Now, what kind of glaucoma do you think it is? Do you think they have glaucoma, or do you think they have OHT? If you think they have glaucoma, or you think there's enough information there to make that, do you think it's open angle or closed angle? And do you think it's primary or secondary? Any thoughts, anybody? So do you think it's OHT or some sort of glaucoma? Do you think it's primary glaucoma or secondary glaucoma, or do you think it's an angle closure, a closed glaucoma, or an open glaucoma? Anybody have any thoughts?
So nobody has put anything in the chat yet. You're more than welcome, participants, to unmute yourself and say, or if you would rather just write in the chat, please answer in the chat.
Yeah, okay, so what I'm going to do while we're doing that, because I'll talk you through it, if nobody...
Question, Miss Obi, is the patient symptomatic?
Okay, yes, they are. They're symptomatic. They've got discomfort, photophobia, the eyes a bit red.
Seems like closed angle is the consensus. There's a few people suggesting
angle. Okay.
Angle.
Open angle. Any thoughts? Anybody?
More information would be helpful. It is one of the points raised.
Again, the age is useful. So knowing the person's 44, okay, it could be, and whether they're dilated or not. Okay. So the big things there are the pressure's really high, and if they are symptomatic, that's more in keeping with an acute presentation. Okay, so the pressure's gone up suddenly, or they've got inflammation. All right, and there is asymmetry, but unfortunately I haven't given you information about the size of the disc. So one disc could be 1.5 meters, the other 2, you don't know. Okay, so that's not very much information, but I want you to start thinking about it. Not everything has to be primary angle closure, okay, or acute angle closure glaucoma, okay, but it's definitely something to think about. All right, and they're symptomatic, that's more likely.
There are a few other comments come through, Miss Obi, if I just add them in. Asymmetry could indicate open angle. Someone else has written it could be secondary to another incident.
Yep.
Yeah.
So, and I think I've done something funny because I'm giving my answer away, but anyway, let's see. So let's look at the rest of it, okay? So I just want to make sure you remember that actually you want to go back to basic principles, okay? So anybody in front of you can be primary or secondary, and they can be open or closed. If there's a lot of asymmetry, it's more likely to be secondary, okay? So a lot of difference between the two eyes is usually, is quite often a secondary glaucoma. So just bear that in mind, okay? So even if the person had acute angle closure with the right eye of something, you expect to see a shallow anterior chamber in the other eye. If you don't, then you need to be thinking about a secondary pathology. So this was their presentation in 2014, 2021 now, vision is 6.5 unaided, which suggests that actually they haven't got much of a refractive error. They're on the intraocular pressure on COSOP, so that's 2 agents, dorzolamide and timolol is 15. They've got a thin cornea, their Van Herrick is 40%, okay? Now, just another word to say that just because a Van Herrick is nice and deep doesn't mean that you're going to be wide open. All right, so when we've done gonioscopy here, this person has a widespread PAS, but the Van Herrick can still appear quite wide. Okay, they've got they're quite cupped at this point, so they were 0.6 7 years earlier. Now they're 0.85. I've put disc diameter there, so that can allow you to interpret those findings. Now that's not a particularly large disc. Okay, so we said 1.5 to 2 is average. So that is likely to be pathological, which means that they've got less nerve fiber layers, less neuroretinal rim area than they should have. This is the disc image, and you can see the thin here, you can see a bit of bearing here, a bit of bayoneting here and here. Okay, so they've got glaucomatous features. They've got a field defect too, so does that match? So here you've got thinning superiorly on your diagram and on the photograph. and you've got the matching inferior field loss. So that makes this all much stronger, that's really glaucoma, because they correlate. If we do an OCT, we get more information, but it's not essential to make that diagnosis of glaucoma, but it is useful for monitoring, okay? And here now, this is just to show you again, we do the parapapillary retinal nerve fiber layer thickness, and we also do the ganglion cell layer thickness in the macular area, and we can put those two together to get the RNFL ganglion cell complex combined, and then this gives you information of how the whole problem started. So you're losing retinal ganglion cells here earliest, and as the axons get damaged and lost, then it becomes more apparent when you get to the optic disc. Okay, so that's the benefit of having this bit now to try and pick up earlier glaucomas. So how do we manage it? The mainstay of managing glaucoma is to reduce the intraocular pressure to a pressure at which you think there's no further RNF, retinal ganglion cell damage because of pressure, okay? That's the mainstay. You might also need to do something about the angle if they've got secondary or angle closure mechanisms. We can lower intraocular pressure with medical treatment, laser treatment, or surgery. And we can do that either by reducing the production of aqueous or increasing the rate at which aqueous flows out. And if we're using more than one medical treatment, we usually try and choose one that does this and does that. So got lots of heap of drops that we can use, tablets sometimes, injections sometimes for the acute ones. You can have laser, and the reason I'm putting laser here is if you've had someone who's got glaucoma and they've had laser, you probably won't see anything when you look at the eye, okay? So SLT, you won't see anything even if you perform gonioscopy for the most part. This is ECP laser applied to the ciliary processes. You're not going to see anything either as well. Surgery is generally geared towards increasing outflow, okay? So you can put things into the trabecular meshwork to improve outflow into the canal of Schlemm, and we can sew various tube-like devices onto the eye with a tube going into the anterior chamber to drain the fluid out. So if you think, but someone is in glaucoma and they're on no treatment, but they've had glaucoma for a while, do ask if they've ever had laser or any surgery, and then you can look for the signs of what they've had done before. Just put in there for acute glaucoma. So if you diagnose someone with acute glaucoma, to help you remember the symptoms, RSV can be helpful, red eye, photophobia, visual loss, and pain. And the principles of management would be to reduce the eye pressure, open the angle. If it's a closed angle, we have to control inflammation because it's inflammation that makes them symptomatic. We need to give them pain control and antiemetics because they tend to have nausea and vomit. I put this, but I'll get you to read it. So there are four main classes of medical drops that we use: prostaglandins, first line, beta blockers are second line, alpha agonists are third line. I'm sorry, carbonic anhydrous are third line, and this is our fourth line. I apologize, I'll change that. That was the wrong way around. This is actually fourth line. This is third line. I'll leave you to read that. But glaucoma is a real problem. It's a greater problem in Afro-Caribbeans. Glaucoma develops earlier, it's more refractory, surgery tends to fail, and they're greater issues, okay? And that's a real problem for us in the Southeast London because we have a really high black ethnicity mix, okay? And in Lambeth, and Southwark and Lewisham and St. Thomas's in Lambeth, we have 27% of our population is black. So, 30% of our patients in our clinics and above will be black. So where do you send patients when you have a problem? If you think they have glaucoma, but you can't do a full assessment, so your findings are inconclusive, or you need any additional glaucoma assessment you can't offer, enhanced case finding is the place to go. If you think they have acute glaucoma, send them to Eye Casualty. If you don't have an Eye Casualty, an A&E. The hospital eye service, and we'll triage everything, is for non-acute referrals, and also patients lost to follow-up. And patients do move around a lot coming into London, and some of them have to transfer their care. So my take-home messages are then, I want you to have a high level of awareness to anyone coming in. So do be aware. I've talked about blacks having a much higher risk of glaucoma and occurring earlier. So typical screening age is 40, but you see a 30-year-old, and I've definitely seen an 18-year-old who's optometrist and missed the fact that she had glaucoma in one eye, and she was complaining that her vision was going funny, and they didn't look at her disc, they didn't look at her field. And 9 months later, her vision had dropped, and she came to clinic with a 0.9 cup. So, just because they're 18 or 19-year-olds doesn't mean that they may not be at risk of glaucoma, and particularly aware of those ethnic risk factors. Do assess patients for their risk factors and include refractive status in your assessment. Think about any relevant ocular, medical, and drug history. I put a few drug things that we may not think about. Ask about steroids, particularly important as a risk for raising IOP if it's put in the eye. And there are some people, you know, if they're on steroids long term, and you do ask them why and when they were last seen. Okay, and if they haven't been seen recently, please refer them on to a GP to be referred. Topiramate is given for epilepsy and migraines, and it can predispose to angle closure, as can sertraline. I was reading up about cannabis the other day. It has two agents, THC, that can lower pressure, and the CBD oil, which can actually increase pressure. So, you know, if they're on CBD oil, for example, be aware that you do warn them that it can increase their pressure. Ask about family history. So the first degree relative is most important. So parents, sibling. Ask about the age at which they've developed glaucoma. So if I have someone who comes to me at the age of 40 with a 0.9 cup, I'm going to tell them to get their family members screened from the age of 30, 25, okay? Because to get to 0.9, you have to have had at least 10 years of glaucoma to get that bad. Find out what type they are. So if I know that POAG is what most people look for, okay? If they have angle closure, I will tell them that. So your family members need to be screened for angle closure as well as other types of glaucoma. If they've got PDS or pseudoexfoliation, then you need to advise them to get their relatives screened for those conditions as well. Do document how severe the visual loss is, and that might help you understand why the patient is so worried. So if your parent went blind at the age of 50, you're going to be a whole heap more worried than you would if your parent went blind at 90, okay? And it tells you that they've got a more aggressive risk of a more aggressive form of glaucoma. Make sure you examine the eye adequately to enable whoever else has to triage to do so effectively. We need a vision, we need an IOP, and I say really, really want to stress, do perform GAT, okay? Non-contact tonometry really isn't very helpful at all. Assess the cup disc ratio and take into account the size of the optic disc and the visual field, okay? And if visual field's inconclusive and all these things aren't very worrying either, do consider doing the visual field again, because quite often people just can't get the hang of the visual field, and that's why it only looks abnormal, because they just can't do it. Bear in mind that up to 50% of people can develop glaucoma at IOPs less than 21, okay? They will often have a thin cornea, which you wouldn't know about until you measure that, but don't assume because they're not above 21 that they can't have glaucoma. You do want to have an idea of the angle, so think about Van Herrick, and that's relevant even if you've got someone who you think might have, but they've got very deep angle. You know, their Van Herrick is, I know you do grades, but we would probably do percentage. So if I say the Van Herrick is 200%, that means it's twice as the size of the depth of the corneal thickness, then that's more likely to have pigment dispersion. Always assess the cup disc ratio in relation to the optic disc size. If the IOP of the glaucoma is very asymmetrical, do think of secondary causes, including some congenital abnormality of the eye as well. If your find is inconclusive, do think about repeating them rather than sending them straight to us with just one minor problem. Okay, you know, we at the very best we're running it 18 weeks for someone, and you know, our colleagues at King's were running it 18 months for a first visit. Whenever you send someone, I do want to see that you've made some sort of effort to diagnose. So give me some idea. I think it's an open angle or a closed angle, and exactly what you're worried about. And do avoid unnecessary investigations. Hey, thank you very much. And I'm going to stop sharing now.
Thank you, Miss Obi, for that whistle-top tour of glaucoma. My goodness, that was a lot of information. We've had a few questions, but not really that many. So I'll start with the first few, and I'm not sure, Gerassimos, if you can unmute, and perhaps this first question is more to you, really. It's a question about waiting times to get into King's for glaucoma. Do you know what the current waiting times are like?
We can usually get a patient in the clinic in about 2 to 3 months at Denmark Hill. I'm not sure at Queen Mary's.
Yeah, that was the next question. What's it like at Queen Mary's? I
think it may be longer, but I'm not quite sure because I don't work there.
Okay. Fair enough. Thank you for that. We'll try and see from the LOC point of view if we can get some sort of idea on what the wait times are like. and get back to the people that were asking. That's in terms of getting patients to the glaucoma department. One of the questions was asked, does hemp oil have the same impact as CBD oil?
I would have to look that up. I assume it does, but I have to look that up.
I only know that CBD oil can increase slightly the intraocular pressure, but I'm not sure about hemp oil.
Because we had to read about, because a patient was asking because they want CBD oil for their arthritis and they were worried. It's to do with the variety of cannabis plant and flower and stuff that's in it, and so it very much depends on the preparation. But I don't know about hemp oil. No.
Okay. Well, it's certainly a good point to raise in terms of learning for anyone who's interested in finding out. They can always do their own research and let us know. That would be lovely. Another question that was asked is, how far do we assess in terms of relationships and family history in terms of glaucoma? So is it just siblings, parents, children, grandparents, or do we take aunts and uncles into consideration as well?
Gerassimos, what do you think?
In practice, we just ask patients, do you have anybody in the family with glaucoma? And they usually tell you, it's very, yes, they will say that obviously first degree relatives are most relevant, but if the patient is aware of other second degree or more distant relatives with glaucoma, we would still make a note and take that into account. It's not as strong a risk factor as a first degree relative, but you know, it's usually patients know about their close family, so they'll usually know if a sibling or a parent has glaucoma. It's very unlikely that they will come to the clinic and say, I've got a third cousin with glaucoma, but nobody else in my family has glaucoma. And if they've got a lot of people in the family with glaucoma, like a sibling and a parent and a first cousin or an uncle, then you could think about a more genetic type of glaucoma, maybe ask them a bit more about their family tree. But in general, you know, we just go with what the patient is telling us. Whoever they know that has glaucoma in the family, that's what we record, and we take more seriously first degree relatives, basically.
Okay.
The first degree relative increases your risk about 4-fold. If you have a maternal history of angle closure glaucoma is really relevant, okay? Because it generally tends to come through the maternal family side for the angle closure. But that's really important. So gender is a bit more important for angle closure. But yeah, it is a significant risk. And I would be asking also, you know, if it's your youngest sibling and you don't have a problem, you know, it was one patient, they had the younger sister has genetic problems, you know, they had retinopathy of prematurity and all sorts of other things, had to have cataract surgery as a child and so on. So that may not be applicable to you. Yeah.
Thank you, Ms. Obi. I have one last question. I'm not sure I understand the question, so I'm just going to read it. It says, if someone has normal fields, disc, IOPs under 24, do we still refer if they have a family history?
No. Keep them with you, please. Gosh, no.
No. So the answer is no to that one. Brilliant. I think that's all the questions for now. Please do ping me a message in the chat if I've missed a question. And if need be, we can always answer it later. Now, I'm keen, thank you so much for that. And thank you so much for answering the questions. I'm keen for us to move on to the actual peer review element, because I am keen for everyone to get their 3 CET points today. I'm going to allocate people into breakout rooms if I can. I'm just going to stop recording first.